Welcome to Family Voices of California Brown Bag Lunch training series. This is a statewide training series on health and policy topics affecting children, youth with special health care needs, geared towards families, youth professionals, parent-to-parent staff, advocates, and anybody else who is interested. Just to give you a little background about Family Voices of California, we are locally based and nationally connected. We are a statewide collaborative of 8 locally based parent-run centers working to ensure quality health care for children, youth with special health care needs in California. We are the state affiliate of National Family Voices, and we receive federal funding under the Family to Family Health Information Center from Maternal and Child Health to help provide statewide support to families of children with special health care needs. If you want some more information, you can visit our website. I want to give you a few notes about how to use the platform today in case you haven't used it before. There are a few ways to interact with our presenter. So if you have a headset with a microphone, then you'll be able to ask questions using your voice. If you don't have a headset, that's not a problem. You can either use the telephone or you can type in your questions. If you want to use the telephone, the call-in number and the PIN are in the confirmation email, or while you're connected, there's an audio menu, and you can select Use Telephone. It'll give you the dial-in access code and audio PIN. If you are using your telephone, please go ahead and enter in that audio PIN, otherwise I can't unmute you. If you have any problems, GoToWebinar is pretty good at helping people get back up online. If you have trouble hearing or anything, you can call them, visit their website. You can also send me, Tara Robinson, a chat or a question. Everyone generally starts out muted because there's a lot of feedback otherwise. So when we get to the point where you can ask questions, you can either use your voice or you can type in your questions. If you have a headset or telephone, you can select the little hand icon. It looks like this on the right. And it's a small column to the left of the menu for the webinar. If you click that, we know you want to be unmuted and that you have a comment or a question. But remember, if you don't have a headset or you're not on your telephone, you'll need to type in your questions instead. And you can use that in the questions pane. You can access any of our webinars. We have lots of them that are archived, and you or staff members or other family members can access them at any time. All PowerPoints and materials will be sent to everybody following the webinar and posted online. And if you have any questions, here's my contact info. And with that, I want to go ahead and introduce today's topic, which is developing and integrating patient and family advisory councils with Libby Hoy from PFCC Partners. Thank you for being here, Libby. We're very excited.
Sure. Am I on?
You are, but you're very quiet again.
Is that any better?
It's a little bit better, yeah. There we go. That's good.
We're good?
Yeah, we're good. So let me just 1 second make you presenter.
All right. How's that?
Great.
So I'm on. Is that right?
Yes, you are on.
Thank you. Hello, everyone. I'm really glad to be here today to talk with you a bit about patient and family advisory councils. Just to give you a little bit of background on myself, I'm the mom of 3 boys living with mitochondrial disease, and from that experience I got involved with parent-to-parent support and later patient and family centered care. So the reason I'm coming to talk with you today about patient and family advisory councils, I am a consultant to several different hospitals on building and integrating and sustaining their advisory councils. And most of that experience comes from my 17 years as the chair for the Parent Advisory Board at Miller Children's Hospital in Long Beach, California. 17 years is not what I would recommend as a guidance for a chairperson. It was a very slowly evolving group, obviously, And we made a lot of mistakes along the way and learned a lot of valuable lessons, and that's why I put together this presentation today to sort of shorten everybody else's curve. Okay, so if at any time you want to type in questions and Tara can help me acknowledge them, I'm happy to have discussion, or if you'd prefer to hold your questions to the end, whatever you choose. So some of the essential components for success, and as I'm going through these slides, the bulk of my experience comes from building patient and family advisory councils in the hospital setting. However, I think that as I've worked with other organizations as well, you can take these principles and apply them within other sorts of settings, whether they be CCS or PTIs or whatever it might be. I think you can integrate these components. So as the starting point, it's really important for an organization to identify their vision for a patient-family advisory council. What is the function of the group going to be for the organization? Is this going to be a group that will solely review documents and policies? Is this a group that will be involved in program development? Is this a group that will be sort of community cheerleaders and ambassadors, if you will? Or is this a group that's going to encompass all of those things? So I think the organizational leaders need to be very clear on what the vision of the group is. Of course, over time, that will kind of metamorphosize into other things, but it's very important as you're getting established to have a very clear vision of where this group is going to be integrated into the organization. Executive leadership buy-in is essential to really launching a patient-family advisory council or sustaining it. If the executive leaders really understand the value of partnering in a truly collaborative and respectful way with their patients and families, they are more likely to support the advisory council, and the advisory council, in order to move things forward, will need executive leadership buy-in. It also sets the table for the rest of the organization. If the leadership is providing lip service to the fact that they want a patient-family advisory council so they can say they have one, versus really integrating those values of partnership, then the remaining staff and people in the organization are really going to follow that lead. So that executive leadership buy-in up front is really important. I think whether you're starting off or really working at sustaining your group, flexibility is really important, especially in our population where we're all raising kids with special health care needs. We can't always fulfill our commitments to the best that we would like to be able to do. Other things come up. And so building in room for flexibility so that as much as you can, not laying the bulk of responsibility on one or two patient and family advisors, but really building that structure so that the structure can carry on despite what goes on with individuals is really important. So building that flexibility in. Is the organization ready to invest time and resources? Is someone identified within the organization to take on this patient and family advisory council? And is that a good match? Sometimes we see where it's been given to one staff member or another who maybe already has a plate full, who doesn't really have an interest in it, or who lacks the skills for communicating appropriately with families. So really investing that time to look at the right staff person to lead this and providing time in their job description to be able to do that. And then the resources. Are we able to provide a room, snacks, childcare, whatever it might be? Patient and family advisory councils don't really require a whole lot of funding, but they do require some. And so really, is the organization really ready to invest that time and resource? Structure for the integration, that really needs to be identified up front. How is the feedback, how is the participation going to occur between these patient-family advisors and the organization? And I think the easiest way to do that is to look at your organization as it exists And rather than trying to build a new structure, how can you integrate it into an existing structure? So for instance, and we'll talk a little bit more about this in a couple of slides, but you know, if you have partnership councils, for instance, in your hospital setting, where those are already unit-specific interdisciplinary teams, can you integrate patient and family advisors into those rather than building a new structure? So I'll give you some more examples about that in a minute. And then the other essential is that your patient and family advisors themselves be representative of the population that is served. So for instance, in Long Beach, we have a broad range of cultural diversity. We need to make sure that all of those cultures are represented to the best that we can. Other pieces of diversity besides cultural is, you know, assuring that kids of all ages are represented on the Patient and Family Advisory Council. So if you have a whole bunch of advisors with 1-year-olds but nobody representing teens in the hospitalized environment, you're not going to get quite the balance you're looking for. And then the other way to be representative is to be sure that you're across all disease diagnoses, as well as you know, acute users versus long-term users versus short-term, you know, whatever it might be in your organization. So how does the vision get developed? There's the organization, again, once you've identified that the senior leadership or executive leadership is really on board with this concept, they need to get together with that staff person who's going to take this on as their project and develop a vision statement. The vision statement comes from the organization because the vision statement is about how are we going to use this Patient and Family Advisory Council? How are we going to structure it? How are they going to contribute? What do we want from this? Again, do we want them to be involved in advocacy efforts within our organization? So just identifying all parts of our organization and all parts that we see the Patient and Family Advisories helping us with those pieces. Really looking at staff education. This is really important. Staff often feel a little hesitant if they don't have experience with partnering with patients and families. They feel a little bit hesitant, a little bit threatened by the transparency. That's an essential part of being a patient and family advisor. And that needs to be acknowledged. It can't just be necessarily demanded. I think the best way to deal with that is to provide sort of the national landscape for patient and family-centered care, the initiatives that have been put out by Maternal Child Health Bureau, Institute of Medicine, IHI, all of these organizations really pointing to this improving our service. And then I think staff really need the opportunity to sort of vent their concerns. I think I've seen that once that occurs and they've really been able to talk about it and had that acknowledged, it seems to move forward fairly easily from there. A couple of things that can help with that is when staff are expressing their concerns, you can put a timeline on it and say, okay, we're going to try this for 3 months and we'll come back and see what you think at that point. And I think that really helps to give them some control over the feedback and give them an opportunity to let you know how it's working out. So how, excuse me, will the organization invest the time and resources to do all the work up front, not just ongoing with the Patient and Family Advisory Council, but really to create the timelines for recruitment, identify the teams for the interviews, pull together the training pieces for our patient family advisors, how this is all going to roll out. Okay, so developing the structure is part of the foundational work. Where is the Patient Family Advisory Council going to rest? In a hospital setting, often it's with the quality department. I think that provides a setting that reaches overarching quality and safety goals and PI projects, and so patient and family advisory councils being closely aligned with that quality department creates that most direct effect. It might lie with the PFCC program manager, although organizations that are starting out with patient and family center care may not have these program managers in place quite yet. And if not, often a child life professional, pastoral care, and occasionally customer service or customer relations or patient experience departments will also oversee the patient-family advisory council. That's just a couple of different options. One kind of caveat, if the customer relations department or the customer service department is overseeing the patient-family advisory council, it's easy to really focus them on customer service projects and kind of going towards the happy patient. I always say that we're not going to be happy patients. We want confident and comfortable in our environment. That's really what we're looking for. So if it is with customer relations, really being mindful that the potential or the impact of patient-family advisors goes far beyond the patient experience. If we really want to integrate them into our organization, we'll have them as part of our program planning, as part of our quality improvement projects, as part of our safety projects, advocacy, marketing, all across the board. So the Patient-Family Advisory Council itself would roll up to either both of these or in succession or one or the other of them. Again, as we start the Patient-Family Advisory Council, they really need to understand the vision the organization has for their connection. I often talk to advisors that are so gung-ho, excited to get started with an advisory council in their organization, and then I talk to them again in 6 months and they say, I'm still not really sure what I'm doing here. And that's because they didn't quite understand the vision. So that really needs to be shared with the patient and family advisors right up front. As the first few meetings occur, or you can do this at any point in the process if you already have a family advisory council, the members should create their mission statement. So the vision comes from the organization, but the members would create their own mission statement that would support the vision. And that's really important so that patient-family advisors feel an investment in the process and in the creation of the structure moving forward. This is just an example of a structure for a single area, so for a smaller organization. And I just wanted to share this again as an example of looking at the structure that's already existing within an organization and building patient-family advisors into that. So this is from the outpatient clinics at Miller Children's Hospital in Long Beach. And what we have is a clinical operations group that wants to make improvements in the outpatient experience. The physician steering committee was already in place. The partnership council, which is an interdisciplinary team made up of everybody from reception staff to RNs to social workers, dietitians, physicians, everybody. And then we integrated a patient-family advisory council. And so the way that they work together is the clinical operations group will identify a project. For instance, we were having terrible issues with the phone and patients and families being able to get through, being able to get appointments scheduled, large issues. So that one issue goes to each of the three groups to work on and come up with suggestions and come up with solutions. And working together, all stakeholders are represented. And so the solutions that we come up with inherently will work for all three groups, and that's really the goal. So that's just one example. The reporting structure is really important to have identified. One of the other pitfalls, and again we'll talk more about this in a little bit, but is a lack of feedback and a lack of loops. So for instance, we take a policy to a patient family advisory council, and they go through it, spend a whole meeting going through this policy and rewording it, reworking it, putting things in, taking things out, and they pass it on to the quality manager, whoever that gateway person is to the executive leadership. That quality manager takes these suggestions to the executive leadership, who are in charge of finishing this policy, and it has to come back down. So once the executive leadership sees the work that the patient family advisors have done, that specific piece needs to come back down. So once those edits have been taken or not taken, the quality manager then takes it back to the advisory council and say, this is integrated, these edits that you did were not integrated, and this is why. And so that's a really important step, so that folks that are giving their time on the patient and family advisory councils are feeling really invested in the organization and feeling really valued in the organization, and that it's not just an adjunct group, but it's really integrated. Bylaws. You can get some great samples of patient and family advisory council bylaws from the Institute for Patient and Family Centered Care website. They have a lot of resources there. And some of the things, the objects in bold are things that you really want to have in your bylaws starting out. So what are the meetings requirements? Are you going to require people be there at 7 of 10 meetings, or be there unless they call, or are you going to offer online and internet because you have such a large area? How are they going to be able to participate, and what are you going to require of them? Activities requirements. If you're going to require that your patient family advisor councils sit on at least one committee in the organization, or that they sit on two or three, that they participate in family faculty presentations. What activities are you going to require your patient family advisors to do? Behavioral expectations, it seems kind of remedial, but I think it's just always better to have it down, that we'll have respectful communication, that in there you can kind of subtly create the distinctions between the Patient and Family Advisory Council and a support group, for instance, so that the expectations are that we're going to be positive, we're going to be moving forward, we're going to be solution-oriented. Any other membership requirements that your organization has, if they need to get TB tested, if they need to get security badges, whatever else, that should all be in there. The orientation and training requirements. So I strongly suggest that every Patient Family Advisory Council member goes through your organizational orientation, because in order to be representative, we really need to understand the organization as a whole. As a patient in a hospital, if I have a child who has leukemia, I'm going to be very familiar with the oncology unit, but I might not be so familiar with what goes on if you have CF in that hospital, or any other disease. So it's really important that they get a global picture of the organization, and that's why that orientation is so critical. And that was definitely a hang-up for us at Miller's, because we short-circuited that so that people wouldn't have to sit through the 6-hour orientation, which seemed like we were doing them a favor, but in actuality, they came in with just those issues, a very limited view of the organization. And then training requirements. I think this is where a lot of our patient family advisory councils really drop off, is a lack of training. And I've done this over and over, this training that we provide for patient family advisors. It provides the context for what their work is. So the objectives of that kind of a training would be to really identify what are the core concepts of patient and family-centered care, what are the benefits of partnering, what is it I'm trying to bring as a patient family advisor, and how do I take my story and make it representative. And those training pieces are really critical for folks to understand the context of their participation in a patient and family advisory council. Excuse me. It's also important for them to, oh, sorry. Oops, I just lost. Okay, so other things that you can include in the bylaws is the nomination procedure. How is that going to work for you? Does it require a staff member to nominate? Can a current patient-family advisor nominate? And is it one person, two people? So, you know, really looking at these pieces and figuring out what's going to work best for your organization, what's going to work best with the structure you already have. The same with the recruitment. How are you going to go about that? Are you going to rely on letters? And we'll go through some of these pieces a little bit more, but you know, some of those things need to be laid out so that if you should have a problem with a patient-family advisor later on who feels like they were slighted in the nomination procedure, that you can go back to these bylaws and really hold firm. Officer identification and responsibilities can be written into bylaws. I think that that's a little bit hard to do right off the bat if you're just starting a patient and family advisory council, because you need a little bit to really understand how the group is going to meet the vision of the organization and what their mission is going to be, and then I think you have a better idea of what officers you'll need to do that and what their responsibilities might be. Term limits is something that's often written into bylaws. I think, again, it's a difficult thing to instill up front if you're just starting a patient-family advisory council. It can take a year or two to really get over the initial stages to where you're really humming along and you're really having an impact. And so to limit those terms right off the bat might not be so good. And then, of course, you'd end up losing almost everybody you started with and starting the process over. So I suggest you start term limits, you know, after a couple of years. What is the policy going to be for a leave of absence if a family's having a child who's in crisis and obviously needs to give them their attention? Can you write a policy for a leave of absence? I think, again, this is a good idea right off the bat to understand how you're going to deal with these things, as is the protocol for loss. We had an experience about 10 years ago where we had 6 of our patient-family advisors lose their child within 18 months, 6 of them. And so we had no protocol. We didn't know what we were doing. It was just, it wasn't healthy for the group, obviously, but very secondary. It wasn't healthy. We didn't respond supportively enough or in a positive way enough for the families that were going through this. So there's lots of discussion going on about do you force a leave of absence after a loss? Do you say they have to, you know, they can return in a year? And I really like one of the ones I saw that just said it's a one-to-one conversation. It's a one-to-one individual decision that can be made jointly between the person who is chairing or sponsoring the group and the family who's experienced loss. But it's something that definitely occurs and needs to be taken into consideration. So recruitment. So things that make people a good advisor, obviously people with patient experience or client experience in your organization. And I would say fairly recently. That's the best, most up-to-date information on how your services are being received. People who have constructive criticism skills. So again, we want to make these groups very solution-based and not get derailed with a lot of complaining and a lot of staying at with our own personal agenda, but folks that really have that ability to take on the bigger agendas and be representative. People with a desire to improve care for others. You know, they may have had a bad experience. Do they go out and share that with people as you should never go to this organization because you're going to get terrible care? Or Yeah, you know, we're really working at improving. I would like to see this improved, and otherwise it was a good experience. So people who really want to improve care for people coming up after. Where do you find them? You can send letters to unit managers, physicians in the units. You can create posters and put them in your environment. I really like the open house forums. I think it provides an opportunity for folks to get involved who might not otherwise have the initiative to do so. So what that looks like is you can go into the environment and hold an open house, have a coffee cart and some donuts. And one of the ways that I did it was to put huge posters up around the room, and one said kudos, and one said complaints, and one said issues. And then people could either anonymously or not anonymously write out what their issues were, and have a cup of coffee and have a donut and be able to put those up. And so we collected all that data and sent that all on along the chain. But at the same time, we identified people through that process who were willing to get involved, willing to give their opinions, and approach them as to become advisors from there. One very creative group I heard uses direct mailers, and they use it sparingly because obviously that's an expensive form of recruitment. But if they had a council who was maybe lacking in parents of teenagers, then they would look at the discharge sheets or whatever they had that collected the data on the patients and looked at the birth dates. And anybody who was over 12, they sent recruitment letters to the home for the parents to get involved. And so I thought that was a pretty creative way to look at recruitment. The support groups and disease-specific meetings that go on at your organization can be great places to talk with people and see kind of who the leaders in those groups are, and see if they're ready to become patient-family advisors. Lobby surfing, just hanging out. There's really no better way to get in contact with our patients and families than just kind of hanging out with a coffee cart and meeting people. Customer service is another place to identify people, and I often get questioned, well, why do we want to go there if all the complaints are going there? Or, you know, you can also include the grievance committee in that. And yes, there are a lot of patients and families who get involved in that because they're frustrated at things beyond maybe with their entire circumstance, not just the experience in the hospital. But more often, there's a lot of people involved in grievance that really took the time to make that grievance because they cared about improving the care for the next person. And in fact, when I got started in all of this, it was because of a bad experience, and I walked into the chief medical officer's office in our hospital and told him my complaint and my concern, and he asked me what I was going to do about it. And then he opened a lot of doors for me to do something about it. So that really can be a very positive place to find folks. So here's an example of a recruitment plan that we used at a hospital, California, and what we were going to do, how that got developed. And again, I'll give these to Tara to pass on. But it's just an example. Community obviously is another place you can go and recruit. If it's a community event that caters to the population that you serve. We had one hospital that would have community health fairs based on, you know, basically what is how to take care of your heart or whatever it might be. And they recruited from there, and what they ended up with was a lot of community members who were interested in their own health but hadn't had any experience with the organization itself. So make sure that it's a targeted community event. Okay. So application and interviewing. the application provides the pertinent experiences and definitely provides a communication style. So, you know, are folks answering the questions on the application in positive terms or in, you know, constructive terms or in really derogatory? It just gives you a flavor of the communication style. And it's an opportunity for an organization to state the commitment up front in terms of what's required. The interview, I think, is really important so that you connect with that person, you know, in real time. It can be done with the staff sponsor and a current patient and family advisor, which I think is a really nice way to do it, because the staff sponsor is there to really talk about the vision of the organization, and the current patient family advisor can really glean information on what it's really like to be involved and share their own experiences, which is really helpful. It can be done staff member alone, but again, a candidate might have some questions for an advisor that might not be answered quite as well as by a staff member. Phone interviews are great, but they do come with a limitation of being able to see how a person presents themselves. But I think, you know, if that's your population and that's all that you can achieve, I think that's perfectly fine. Okay, let me get you an example of an application. So obviously contact data. And then this part down here is where people can really tell you where their experiences have come from. And then what activities they might be interested in. So again, your vision for the organization would drive these activities, this activity list. So however you see patient and family advisors getting involved, that would be where you would put these activities, the coordinating activities in. And any areas like a parent-to-parent support program that would require extra training. Okay? Asking these open-ended questions to me is really critical in listening to people explain why they're interested in joining a patient and family advisory council. Again, if it's a bad experience that they want to improve, you're going to get that. And if it's a bad experience that they don't think can be improved, or you know, there's a specific physician they have a beef with, or you know, whether it's to right or wrong, it just tells you where people are coming from. And it doesn't mean that you wouldn't take that person who had a beef with a specific physician. It just means that you understand their priorities and you have that conversation with them in their interview as to how they're going to work that out, or how they see that being worked out. Any other committee experience they've had, if they like public speaking, and we have patient and family advisors that love to speak to groups and others who don't, and that's fantastic. In a patient family advisory council, there's something for everybody. And then these two open-ended questions down here, I think, really are very helpful in identifying someone's communication style as to how they're going to present both a positive experience and a negative experience. And then more information about attending meetings. Okay. So orientation, as I mentioned, whether it's a hospital or your organization, whatever orientation you would put your staff member, an onboarding staff member through, I would put your patient family advisors through, just so they get that context of what the organization as a whole is all about. An advisory board orientation is a good idea, again, stating the meetings requirements and how best they can attend meetings, the required activities, go over the expectations and the bylaws if you've instilled those at that point. And then a patient and family-centered care orientation or training. I think this is really, really important. And when I went into an organization that had established a family advisory council and then brought me in for this training about 1.5 years later, and I just remember this gentleman coming up to me afterwards and saying, "Oh, now I understand what I'm doing. why I'm participating in this. So they, you know, we seek patient and family-centered care experiences without always understanding exactly what those are and being able to articulate the value of that partnership. And so it really does provide that context. It also gives folks a chance to tell their story and to see how, part of this training is to see how their story layers on to the vision for the group, the mission for the group, and how to take that from your own personal agenda to that representative agenda. So some of the first meetings, if you're just starting a patient and family advisory council, you can expect that the first maybe 3 or 4 meetings, if you're meeting monthly, would be taken up by these activities, reviewing the bylaws, but also providing folks an opportunity to tell their story. When patient and family advisors are getting involved, they're doing so because they have a personal, very personal story that's compelling them to become more involved. And as a group, they each need time to share that story so that they kind of connect over those. You can establish the expectations and review the foundation work that's already been done by the organization to look at the organizational structure for the group, showing them that, when you have your input on a particular program design, it's going to go to this next step, it's going to go to that executive leadership, and then it's going to come back to you, and really showing that organizational structure and attaching the names for your organization. It's also important to review the organizational structure from a human resources perspective, I think. I worked with one council who had no idea what the name of the CEO of the organization was, had no idea how to contact them or even if their office was on the campus. And so that kind of, it's not that the patient family advisors are going to have direct link to the CEO, but they should have enough understanding of the organization to see, what that structure looks like. The mission statement can take 1 or 2 meetings by itself to really come together, and after you've done that storytelling and after that training's taken place about how do I take my personal story to that representative level, then folks are ready to work on a mission statement together. And then once the mission statement gets developed, you can do an exercise or however you choose to do it to create the priorities for the organization. A lot of organizations will start out providing the priorities for the group. And I really think that allowing patient and family advisory councils the opportunity to develop their own priorities really gives an organization a very important glimpse into how their services are being received. So, for instance, if an organization is very focused on hand hygiene and they're going to make that the biggest priority because infection rates need to come down in their hospital, that's going to be very important to patients and families as well and needs to be presented as an option. But they may feel a more critical issue is how kids are routed through the emergency department. And so oftentimes patients and families who are utilizing your services are going to have a better idea of where your priorities need to be, not maybe a better idea, but an idea of how you can best improve and target improvement for the people that you're serving. And I wanted to show you one example of a priority development. So we did this in a hospital in California, and we went around and brainstormed for an hour about all the things we wanted to improve in this children's hospital. And then everybody went around and voted on which ones were their favorites, which ones they really thought we should do, which ones we should probably get to in a year, and which ones didn't require resources at this point. And so this was the development of the priorities for that particular group. Okay. Oops, got ahead of myself there. I already showed you the example. But it also, again, provides that the organization, the strategic plan for the group. And pretty much covered all that. I do like a work plan or a priority development sheet that has a nice combination of some quick wins and some long-term goals. Another way to alleviate some of the staff concern at having a patient-family advisory council is to do some positive things really quickly off the bat. And when we rejuvenated the Parent Advisory Board at Miller's, one of the first things we instilled was a Parent Choice Award, where we nominated a staff member or volunteer who went above and beyond for patients and families and really partnered. And by highlighting a staff member who exhibited those behaviors in a way that we were really excited about, they became examples for other staff members, and it was just a very positive, quick win. So something like that. And then some more long-term goals, so kind of a mix in your priority development plan. So here's a slide just of all the ways that patient-family advisors can help you in your organization. They can partner with you on quality initiatives, safety initiatives. They can participate on committees across the organization. So wherever you have groups in your organization that are charged with improving the organization, those are really great opportunities for patients and family advisors to get involved and really provide that perspective so that you're certain that your improvements are going to target your population accurately. They can provide family faculty presentations, which are so meaningful and impactful to providers, both in a way of, I remember talking to one 7th floor intensive care unit group, and they were a little bit nervous about having me in there. They kind of thought I think that I was going to come in and tell them how to do their job and why we hated it and all of that. And I think staff members really need to be empowered too, and it's really great for family faculty members to come in and yes, talk about some of the ways that we need to be partnered with more, but also to talk about the ways that all the things that are going on in the organization help support their families and support us to raise our kids. Peer support programs, what Family Voices does so well, is another way to integrate. Document review, program design, foundation efforts at fundraising. Patient and family stories are very powerful ways to get funders involved in your organization. Marketing events and staff appreciation. Not sure where I am on time. Okay. I'm just going to go through this super quick and then have some time for some questions. I mentioned the customer service oriented. Just make sure that the perspective goes globally across the organization and doesn't just stay with the patient experience. Failure to close that loop is a common pitfall. Letting folks know the information that they provided or the work that they've done has been integrated or not integrated and why. Being careful that patient-family advisory councils don't become support groups. That's a different and distinct mission. Meeting attendance can sometimes drop off if you're in an area where people have to drive a long ways or whatever it might be. Look into just what we're doing now for your meetings and provide some flexibility there. The resistant staff, we talked about how to get through that. And then balancing strong personalities. Sometimes we have strong personalities in the group and personalities that aren't as vocal. And so it becomes incumbent to really provide some creative ways, such as the sticky notes or the anonymous notes or what you might have to provide an opportunity for folks that are tentative to speak up. So, frequently asked questions. Should we have term limits? We talked about those. Avoiding the meetings turning into support groups, and also balancing the strong personalities. I think that can really be done with a strong agenda. And again, if the agenda is set by the group, or at least strongly influenced by the group, then you have a lot. They're invested in staying on track. Okay? Sustaining momentum, you can do that by creating that feedback loop and continuing the integration. Okay. The right staff advisor ratio, I don't really have a hard and fast rule on this, but my preference would be 75% advisors and 25% staff. The staff members that should participate are going to be identified by your organization as part of that vision and agenda. The right time for group ownership to really turn over to the officers, I think, is, it's hard to say a hard and fast rule. I would guess around a year, but really more when they have completely taken ownership for the agenda, there is integration, there is a feedback loop is closed, and things are really humming along is the right time for the group to take ownership. So there's some resources, and if there's any questions.
Well, thank you. Okay, guys, so now it's your opportunity to ask questions. If you have a headset with a microphone or you're calling by phone, you can be unmuted and you can do the raise your hand thing. Or if you don't and you're just listening to it on your computer speakers, then please go ahead and type in your questions now. We have a few minutes for questions.
Sorry about that. I kind of went long.
No, it's fine. Thank you for compressing this. I know it's a much longer presentation in person. Just give people a moment. It's your time to ask questions now. I'll ask one while people are gearing up. In your experience, Libby, what typically are the responsibilities or decisions that the council is given? And how do issues make the agenda?
I think that the agenda gets made after the priorities are identified. So when the patient family advisors, I haven't really seen a group that lacks any ideas for priorities. So I think once those are identified, then that kind of runs the agenda. But in terms of how agenda items are brought from the organization to the Patient Family Advisory Council, that's brought through the employee sponsor, whoever the staff sponsor for the group is. And typically those, especially in the beginning, are a lot of policies to review. That's sort of a safe thing. And then as that trust gets built, it goes on to, we really want someone involved in our hand-washing initiative, or we really want these advisors on our improvement committees. Okay,
interesting. Okay, folks, don't be shy. Have a few more minutes. I'll ask another one. I was wondering, if you are a family member at a hospital and your hospital doesn't have an advisory council, but you want to be able to provide input in some way, where would you start?
I would start with a customer service person. And if you can go and talk with them about, get some of your resources together, so go to the IHI website and go to the IFCC website, some of these other ones, and arm yourself with some information about what's going on across the country in terms of patient and family center care and how critical the patient family advisory councils are to that effort. I think that's a great first starting point. If you can get to anybody higher up, if you have any contact through your child's care, you could do that as well. The other way would be to talk with your child's physician and see how he or she feels about patient and family-centered care and advisory councils, and see if you can get them to champion along with you.
Gotcha. Okay. We have a question from Joan. Joan, I'm going to unmute you. You there, Joan?
Hello.
Hi, Joan.
Hi. Hi. I had a question. We're starting a family advisory council at Children's Hospital in Oakland, and the question I had is, how do you ensure that the members of the council are representative of the patient population?
Well, I think it's on your application because they're going to be identifying the places they've been across your organization, and then if you've got a lot of Spanish-speaking or other languages, you're going to translate that application so that it's available to other cultural, so that you're covering that aspect. But you're going to have the information as far as covering, different diseases, different areas of the hospital based on your application.
Okay, so you do it by disease as well as culture?
Yes. Yes.
Is that what you
Because
suggest?
it's disease, it's culture, and then disease, and then also the age grouping, so that you don't want to end up with a patient-family advisory council made up of parents of toddlers or babies and not have the teens represented or not have the middle, school-age kids represented. So those needs are going to be different, and you can put that in on your application.
Okay, great. Okay, thank you.
Sure.
Thanks, Joan. We have a question from Pam. Pam asks, how do you find out if this is already in place?
You should be able to start asking. You can start with your child's providers and ask them, and then if they don't know, you can go to whoever the person is that is in charge of improvement. So whether they call that person a quality person or program development person, whatever that title might be, that would be the person who would be most likely to be involved with the Patient-Family Advisory Council. But if there is one and it's functioning, I would think most people would know about it, most people in the organization.
Okay, great. We have a question from Arlene. Arlene says, within the Los Angeles County Public Health Department, there's a culture of change occurring from administration top down and not from the ground up. So would you recommend starting in the outpatient clinic area as a possible route to break into the culture?
That would be one way that you could do it. It would be hard for me to answer that question without understanding the organizational structure that you're working within. But you have to have that top-down buy-in, so that's actually the harder piece to get typically. So if you have that, I think, and you're putting out there that you want to become involved as a patient-family advisor or you're interested in creating this, certainly if you can rally other patients and families within the outpatient clinic to move that forward, I would think they'd be very receptive. But you've already got the harder part.
Great.
Hopefully that answers your question.
Yeah. One last question, because I know we're at time and I want to be respectful, is Libby, do you think that these kinds of patient advisory councils could be used as a model on a larger scale, like, for example, in a health plan, something that's not just one institution specific? Have you ever seen this implemented?
I think we're moving towards that direction. I think the IHI is doing some really great things in that area. In fact, I really believe that it's the only way that we're going to really improve healthcare is to have patient and family advisors alongside the providers, alongside the payers to really improve care, because that's the way that you guarantee all stakeholders have been heard and understood, and that way it will work for all three. So I think there are movements towards that, and I'm excited to hopefully become part of that.
Great. Oh, we have one more question. Okay, here. This is the last question, as my son likes to say. What about at the teaching level of the hospital? Are these groups working with the professionals just starting out or still in school to improve care that way?
Yeah, that's a great opportunity. If you're in a teaching hospital, to really have an established patient-family advisory council means that you can start to impact that teaching aspect. You can start to have family faculty presentations to residents and folks just starting on their medical or their healthcare careers. And that's just a fantastic point. There's all kinds of programs out there. I'm forgetting the name of the one in particular, but where residents actually go and spend a day in the life of a family raising a child with special health care need. And that you can imagine how much of an impact that has on someone at the onset of their career. It's very powerful. So, hopefully, and that's the other reason for training of our Patient Family Advisory Council members, that they really confidently can articulate not only their own story, but again, representative, so that we can really have those impacts on all levels of healthcare professionals.
Great, thank you. Thanks everybody for your questions, and thank you so much to Libby. And just as a side note to everybody, Libby has just founded the PFCC Partners, so it's this brand new, really interesting organization, and I encourage you to look at her website for more information on this. Thank you so much, Libby.
Absolutely, thank you.
And as a follow-up, everybody will receive a survey. Please fill it out and take the time to do that. And if you're not already on our listserv to find out about trainings, go ahead and visit our website to sign up. Thanks for coming. If you have any question, you can contact us at info@familyvoicesofca.org, and we will be sending out a link to the today's presentation, including materials that you can view at any time after this is over. So thank you so much, and we'll see you next time.